and then I'll mute. Do you want to start letting everybody in and
at noon? Yep. Yeah. Ready?
All right. Welcome. So this is our third in, I guess now we have 4 total. Next week, we're going to talk about corrections. But first one, we talked about adolescence. The second one, we talked about trauma. And in this one, we're going to focus on neonatal abstinence syndrome and pregnancy and kind of a conglomeration of all of those pieces. And with that, we're going to need to still remember some of the things that we talked about previously, as well as some things that we want to make sure and learn that are new. Again, there are no disclosures here. Everybody is disclosure free at this point. And for the objectives this week, we're going to be looking at making sure that we can understand how to best kind of screen and assess for SUD in pregnant mothers. I'm not going to spend much time on that. It's going to be more of a conversation, but I think it's important. I want to make sure that we can apply this knowledge in how we treat mothers with SUD. And then I'm also going to walk you through a combined effort of myself and Stanford when we built there in California, a mother and baby substance exposure toolkit, or the nastoolkit.org. And we'll walk through that website a little bit at the end, because it walked through a number of best practices for what you can do pre-hospital, in the hospital, and in the NICU to really improve the treatment of the dyad, and the dyad being the mother and the newborn. If we let's start with a patient. And this is a patient I mentioned a little bit earlier in one of our talks. So this is Kayla, life stage 1. So her adolescence, she had a family history of addiction, and genetically speaking, that family history of addiction increases your risk and pretty substantially, and is probably responsible for about 60% of your total risk analysis, as best as we can identify. She had moderate early life trauma, parents divorced, single parent household, some domestic violence, early sexual assault, early substance use, including marijuana and alcohol in high school, and then immediately after high school, heroin, and then elective pregnancy termination at 17. So this was kind of her adolescence. And early adulthood, which is when I initially saw Kayla. She had an addiction to oral opioids. She was on about 400 morphine milligram equivalents a day, sometimes 600, depending on how much she could get. She had very poorly controlled anxiety and was also utilizing benzodiazepines and would smoke marijuana intermittently. She, again, is pregnant, and really no social support. The father of the baby's out of the picture. And her mother steps in and out, but creates as much chaos as she helps to alleviate. So not a great situation, but one that's relatively common in this subset of the population. So if we're going to look at Kayla and we're going to talk about screening and assessment, we have to keep in mind when we're doing screening, which, remember, screening is identifying someone who is at risk for a condition. It's not diagnosing it, it's just screening. So if somebody comes into the emergency department and they're intoxicated, that's a positive screen for a risk of having an alcohol use disorder. It doesn't mean they have one. And we have to do an assessment after that to evaluate if they truly have the diagnosis, and if they have the diagnosis, what is the severity. And in pregnancy, generally less than 10% of OBGYNs screen on a consistent basis for addiction in general. They will screen for tobacco, and they'll screen sometimes mostly for alcohol, but the way they screen is not using a validated verbal screening tool, and that becomes really important. And because addiction is so complex, it's important that we use validated approaches to identifying this. So if we use like the 4 Ps, which is a standard screening tool to identify, it comes at it sideways a little bit. It comes at it from have you been in a car with someone who's been intoxicated or on drugs, instead of have you driven a car? So it allows for them to say yes to some things that may feel more comfortable. And that gives us a good sensitivity in that sense. It does dig in a little bit to how much drug or alcohol they were using prior to pregnancy versus during pregnancy. So the 4 Ps or 4 Ps plus is one that seems to be working well. It's used in a number of places in California. However, it's not much better than the NIDA 4, the standard National Institute on Drug Addiction 4 questions. And all you have to do is tailor in the last 3 months or 6 months piece. And you could say, in the last 3 months, have you used nicotine? Yes or no. In the last 3 months, have you had more than 3 drinks, 3 alcoholic beverages at once, or more than 10 in a week? In the last 3 months, have you used an illicit substance? In the last 3 months, have you smoked marijuana? These are things that if they are yes to any of those, then it leads us to the next phase, which is the screening. And the screening is what's really important, because now we need to take that identified risky behavior and determine whether or not Kayla meets for a substance use disorder, and specifically an opioid use disorder or alcohol use disorder or nicotine use disorder, because each of those independently affect the risk of the fetus, the risk of her maintaining the dyad, and then the risk post-delivery. And we have to do that. And that's an entire talk in and of itself. And when we get to the website, all of those things will be on there at the end. So I don't want to spend too much more time on it, but just recognize that if you don't, in a family medicine office, an FQHC, an OBGYN office, or an OB triage, do standardized screening and assessment, you are missing one of the highest risk disease processes in pregnancy. And especially since if you identify opioid use disorder early, it's treatable and we can stabilize patients. So when we look at Kayla, let's say we've identified the positive screen and then a positive assessment. We need to make sure that we don't relay to Kayla the stigma and frustration that we have that goes along with this. And this is a pretty common issue, right? I mean, how many times have you heard somebody say, "You're hurting your baby"? It drives me freaking insane when I hear people say that, because at the end of the day, the guilt and shame held by somebody with addiction is already substantial. And the trauma that they hold is also significant. And so now they've become pregnant. Very rarely do people initiate use during pregnancy. So the greater than 98% of people who you see initiated use way before they ever got pregnant. And so because of that, they had the disease as a pre-existing condition to pregnancy. So telling them they're going to hurt their baby for a chronic neurobiological disorder that they can't just flip a switch for is just adding more trauma. So you have to be really careful about how you approach it. And we talked about what trauma does. And if you continue to add that, that is not going to drive her to get more care. That is not going to drive her to be more connected to the treatment modalities. So taking all of that into account, Kayla is still responsible for her portion of recovery. So once we've initiated a trauma-informed approach and we've stabilized her initial treatment and we've started her on meds or whatever the appropriate pathway is for her, she is still responsible for that. And you have to make sure that that she knows that. You have to have that conversation. Now, Kayla, again, had pretty significant early life trauma. And so that trauma-informed care approach is there. And so trauma-informed care, as we talked about last time, is very much starting from a position of what happened to you rather than what did you do to yourself, and listening to that, being accepting of their history, being accepting of who they are, and allow them to gain trust so that we can be much more therapeutic in our approach to them. So recognizing that addiction is a treatable disease, you have to be optimistic. We're so happy that we've identified this now because we can get you into a great place of treatment. We're going to work through this all the way through and after pregnancy. So I just want you to know we have your back, and whatever you need, we can get it for you as we start to move through this. that positive interaction goes a long way to second visit follow-up as compared to, if you're using any of these substances, you're hurting your baby, and I know you don't want to do that, so you should probably stop. That's just not going to work. So the reasons that we can bring up is to use motivational interviewing techniques with her are these conversations very specifically about, aren't you a little bit sick of all this chaos? It's got to be really scary and very frustrating, and definitely not a place that you want it to be. And since you're here, we can definitely help you with all of those pieces. Or why don't you tell me a little bit about what you think would be, maybe improved or better in your life if you stop using? What are your thoughts? Not trying to, impart on them our thoughts of what would be better, but really getting them to be introspective and helping with that. That initial interaction becomes very important, and it doesn't matter where it takes place as long as it's done in an empathetic, trauma-informed way. We significantly increase the chances of getting Kayla into treatment, especially because the motivation level of a pregnant mother-to-be is the highest of any of the patient populations that I've treated. And I have said before, I've run a clinic dedicated to pregnant and parenting females. And it is my favorite group of people to treat because it really does, in my mind, stop that cycle that we see. And the way that you stop the cycle is you get mom stable, you birth a healthy kid, you send a family home instead of shooting a kid over to foster care and a mom to jail or to a purgatory of, away from her kid. So as we walk through this, just keep in mind, most females have the disease of addiction prior to ever getting pregnant, the vast, vast majority. And so it's not like they got pregnant and now I'm going to start using. They had this disease as a pre-existing condition, and now we're having to deal with the pregnancy on top of that. But interestingly, that acts in our benefit in the sense that it is a very motivating time in life to be able to get someone initiated into treatment and stabilized in treatment. Some of the problems that come up, though, are these big barriers. Is that, Kayla's going to be pretty wary of being honest early on, because all the stories that you hear on the internet, that you hear from friends of, if they know you have it, they're just going to take your baby away. They're going to take it away. And sometimes we do a bad job of understanding what the reporting requirements are, the regulations actually are. I mean, in California, you are not required to report to Child Protective Services if the mother is pregnant and positive for a substance or has a substance use disorder. You're not required to do that. And so if a person is willing to get into treatment and get stable, I would say, don't do that. And the regs back that up. Now, if she is presenting with a significant risk of harm to herself and others that she is unwilling to stabilize and work through, that's a different piece. But the regulations in California are pretty clear that you don't have to report just because there was a positive UTOX or a positive admission for that. And it's the last thing that you're going to get somebody to get involved in care is to say, well, I'm going to call CPS. Now, that's not to say that there's not a time and a place for that. I've had moms that we've treated where they were sitting there when we called them, though. We knew they weren't safe. We knew that we had to do something. And so we initiated the call after we had the conversation with moms. I just don't think things are going well. I'm really concerned about what's going on. And so we're going to call. We'll go through this together, and just know that we're going to continue to work to get this taken care of as we go. And then the other barrier is once we identify this and it's in their record now, if you send them out for high-risk OB or you send them out for evaluation at the hospital and they see that in their record, they will rapidly and effectively be belligerent to that person. It is amazing to me how mean people can be to someone who is as vulnerable as a young pregnant mother who has a substance use disorder. And so we have to make sure that if we levy this diagnosis and we send her for follow-up treatment, that we've let the people know who we're referring to that we know this. Please don't push on this in a negative way. We're handling the follow-up. We're trying to get it taken care of. And if you can't agree with that and you can't, kind of make sure that that's going to happen, it's worth just not doing that consult. It's worth just doing a telephone consult with them as a curbside to try to get an idea before you send them there, because that is the fastest way to get them out of care. So the counseling for somebody like Kayla, and this is a really important component, those are basic things. So obviously CBT, DBT, trauma-informed care, those are the kind of the standard approaches. Now, Kayla, if we dug into her a little bit, has a little bit of a histrionic personality and some other antisocial stuff. So she would do well with dialectical behavioral therapy, manual-driven pathways for that. But in general, CBT and trauma-informed care focused heavily on relapse prevention, and then really dealing with things like the coping skills and connection to case management. The coping skills are really important, and that's more solution-based therapy in the approach in that setting. But think about this. I mean, for those of you who are listening to this who've had kids, you'll recognize that finding out that you're about to be responsible for another human being is a little stressful. And if you have unstable income, no real familial help, and you're about to be a single mother, and you have a disease, it's even worse. And so as we start to stack those things together, we have to start teaching them strategies to emotionally cope, and then also to come up with solutions to problems instead of panicking or giving up. And many times this requires a little bit of a very significant connection to case management. And if you have in your locality some peer support of those who've been through this, specifically females who've been pregnant, if you have that, that's great. We were able to develop that over time as we kept seeing moms in the setting. But it is important that they feel like somebody has their back, and that the person who's listening to them understands what they're going through. Because if you don't teach them coping skills and you're not connecting them to things like case management and peer support, then they're gonna basically bounce to the drug to cope, because that's what's been happening in the past. And if it gets too out of control, they're not gonna feel like they can do it. And if you remember, their default mechanism is gonna go to the thing of highest value. And conflict, a spike in anxiety, and then that default pathway is going to be to find a drug, unless we break that connection between the default pathway and the thing she finds valuable and switch them. Meaning, we now make the pregnancy being healthy really valuable, and getting to that next visit being really valuable, and that default behavior to have a new behavioral pathway like mindfulness-based cognitive therapy, or to pick up and call a sponsor, or to call a peer, or to call their therapist or a case manager, rather than defaulting to that behavior of use. But if you don't add counseling, we can't do that. And if you just hope and think in magic, and if you rub a couple sticks together that magically she's going to just show up and be better, then yeah, there's some issues we need to talk about, other than possibly how you're treating patients. As we look at the effects on the fetus, this is what comes up all the time. And sometimes there's a misperception about a lot of these things. So if we talk about what happens with opioids specifically, if we don't have any known fetal anomalies if the opioids are taken in a stable fashion. There was one study that showed a decrease in the overall brain mass, but they didn't look for stability in the mom, meaning that we don't know genetically if that was just something that had happened previously, or if there was something else from a nutritional standpoint or location standpoint or predetermined genetic standpoint that did it. But even with the the smaller percentage of gray matter, they didn't identify any clinical outcome differences down the road. So we weren't able to identify a phenotype that was of any different when we saw those people. When we look at the higher incidence of prematurity, definitely if someone's still using heroin, there's a super high incidence of prematurity, because they're going through these cycles of intoxication and withdrawal. And as you get closer to in the third term of pregnancy, if you go into severe withdrawal, that can increase your risk of preterm labor. And then also nutritional supplementation and vitamin intake, thiamine, folate, all of those other things that become really important for maturation of a fetus in that setting are not great. And so prematurity can be at the top of the list of that. Methadone had that as well, but it's only basically 5 days difference. So you were still delivering ultimately a term baby at 38 weeks and a couple of days. And then other oral opioids, they found that a few days earlier. So it's not like a trimester early. It's not a premature delivery leading to ICU stay that was different with the exception of heroin. It was just that it was a little earlier. Now, birth weight for methadone and buprenorphine were close. Buprenorphine had a little higher birth weight than methadone. Other opioids that are just prescribed for pain seem to be equivalent to what methadone and heroin were. So basically not a significant difference in birth weight for that. Neonatal Abstinence Syndrome, as we dig into this a little more in this, you're going to understand that that is an umbrella term. Some people will even say NOS, neonatal opioid, or NOWS, neonatal opioid withdrawal syndrome. That's too specific, because if you've done this work for a while and you've treated people with addiction, you recognize that rarely are they a mono drug user. So typically you're not going to just find someone who uses only opioids. And so your withdrawal syndrome is going to be complicated by other things. And there are many other things that can push on that. And just as a quick preview, things like SSRIs, selective serotonin reuptake inhibitors, and pretty commonly prescribed antidepressants can also have a withdrawal syndrome. Nicotine can have a significant withdrawal syndrome and has a mortality rate associated with it. Benzodiazepines obviously have a significant risk of withdrawal and associated seizures. Alcohol, we would understand that one, but marijuana as well has significantly increases the risk of severity of opioid withdrawal and prolongs it. So if we only look at one substance, then we're missing the boat in a sense of trying to come up with a better predictive value of what we should expect for withdrawal. But I'll say very specifically, it is impossible to predict the severity and length of withdrawal based on any factors that we have right now, because it's not related to the dose of a drug. It's not directly related to dose of a drug. It's not directly related to other drugs. It's indirectly related to all of these things. And so we have to figure out really as the baby's born, and we watch him for the first 72 hours, and that helps us to understand. So what about the treatment for Kayla in this setting, right? So we talked about the behavioral therapeutics. We have to screen, we have to assess, we got to make sure that we've identified it, that we've had trauma-informed care, that we start from a place of empathy and acceptance. So what do we do when Kayla goes, well, what should I do? Well, if we look at the abstinence-based treatment pathway, we find that it's only 16% effective in preventing relapse during pregnancy. So that's problematic because 84% failure rate is not an okay thing at this stage. If we look at methadone, we're looking at between a 65 and 80%. It's closer to 80% for pregnant patients. And it had for a long time, been considered the gold standard. I think we're probably at a time now where we're just about to flip that, where methadone, while having been considered the gold standard because we had a lot of data, we had a lot of understanding and a lot of use and programs built around this. In fact, where I trained in emergency medicine at Jefferson in Philadelphia, the OB program, even back in late 90s, early 2000s, when I was there, had a methadone treatment pathway for pregnant patients. So this has been going on for quite a while and is not new. However, the emerging data, the first of which was the mother study, is now greater than 5 years old. And what that tells us is that buprenorphine is probably better than methadone at decreasing post-delivery complications and length of stay. So we'll have to talk about that a little more, and I'm happy to answer questions as we get towards the end. If we look at other MAT benefits in general, and we've dug on this a little bit, but since we haven't had a real focused addiction treatment talk, I feel like I need to make sure that we're all on the same page with this. Putting someone with an opioid use disorder on buprenorphine or methadone, and in some instances naltrexone, not really indicated for pregnant patients, but we definitely stabilize fetal levels of opioids. We reduce repeated prenatal withdrawal, which decreases the stress on the neonate and improves the chances of going to full term and delivering at a normal birth weight. And making sure that mothers are linked to treatment, that decreases HIV, hepatitis B and C, reduces transmittal during the birth so that they can be on the right medications, especially for things like HIV, where if they're on HIV treatment medications, we have a really, really good chance of birthing a child that does not have HIV. So this becomes really important in identifying it. And those treatments are all improved if they're getting treatment for their substance use disorder. So long-term health outcomes for both mother and baby improve with prenatal care with MAT for moms. So this is a really important thing. It's not just the moment that she's pregnant that we're improving the outcomes for her. This is down the road, and we have these longitudinal studies that are still actively going, and they report intermittently on these data. And the data is showing that at 1 year and 2 years, and we're at 3-year data now for these larger ones, and it still shows, as compared to the controls, you have a decreased mortality rate, an improved functional rate, and an improved likelihood to go to pre-K. And all of these little things we're starting to see roll out with a decrease in foster care utilization, decrease in criminal justice, family court. All of those things are better. So if we look at the untreated pregnant women, we would say, well, I don't want to cause NAS, neonatal abstinence syndrome, because I'm putting them on opioids, so we're definitely going to have it. I'll get a little bit into that later, but we decrease the severity and intensity and risk of it if we know the dose and it's consistent and they're not actively using other substances. So it is better in every publication done for mother's outcome to be stable. There are a couple of publications that were pushed out to determine, can we wean mom? Is it possible to wean mom off of opioids so that a baby can be born without neonatal abstinence syndrome? The answer is, it is safe to wean. It is safe for the baby to wean mother off of the opioids if mom is in an inpatient setting, but they never follow past delivery about what happens to mom and baby. And is it worth that length of time just to take away what now looks to be a 4 to 5 with little more than focusing on eating, sleeping, and consoling? It is not what it used to be in the treatment of NAS, is what I'm saying. So making sure that mom is stable, we've decreased her risk of relapse, we've decreased the hepatitis C, decreased overdose deaths. All of those are improved with treatment, and you take that away, that goes away. And locking mom down doesn't change that, especially because the vast majority of mortality for mom happens after delivery anyway. And they've never looked at what it does for that. But we know that not being on MAT significantly decreases your chances of survival over time. And being on MAT, meaning that you're on a buprenorphine, an naltrexone, or a methadone. Well, actually, the research now, 2 large cohort studies just came out, and medications that decrease mortality over time are buprenorphine and methadone. Naltrexone did not have a statistically significant impact on mortality when they looked at those. So really the only ones that we can say decrease Kayla's risk of death is methadone and buprenorphine. Buprenorphine in pregnancy, let's dig into that. I mean, so this medication, it's category C, but only because it just hasn't been fully tested in pregnant patients. It takes forever for things to get to category B in pregnancy, but we've identified that it's well tolerated. We're not finding any increased risk of anomalies in the kids, as we stated earlier. And so because of that, within the next 3 to 5 years, it's probably going to flip to a category B. And that would be, I think, helpful for making people feel better. A question that comes up a lot of times for this is, what about buprenorphine by itself versus the buprenorphine naloxone, which is the combination product? Reason we have the combination product is so that it has less diversion capability. And what we're finding now is that large European studies, as well as those in the United States, show that the combination product does not seem to impart any increased risk as compared to the mono product. However, the mono product is diverted a lot. So my patients, I generally only use the combination product, like Suboxone, Bunavail, Zubzolf, those products, rather than Subutex, which is the straight up buprenorphine. For Kayla, we're gonna, when we start her on this medication, we take things basic things into consideration. And, what was her dose of oxy and hydrocodone? Was she super high dose? If she's on these short-acting medications, she's probably going to have pretty rapidly developing and high-intensity withdrawal. if we gave her buprenorphine. So we have to, make sure that we do it in a thoughtful way. And she's also on a benzodiazepine and smoking marijuana. So with this, we have to take all of these things into account. And it's not just a game, where you try to just replace one for the other, and making sure that we do it in a way that has a good policy and a procedure. And this is pretty well published now. And I've done a few hundred, inductions for pregnant patients on buprenorphine now. And so we can talk to the specifics, but at the end, it's pretty straightforward in how this works. Let's see, where would we do an induction for Kayla? So the first thing is that we had talked at the beginning about doing a screening and an assessment. So the assessment says presence of disease and severity of disease, and that's helpful. But in order to know where Kayla needs to get treatment, meaning does she just need to go to an outpatient treatment provider, to a methadone clinic, an opioid treatment system, or to level 2.1 or 2.5, like intensive outpatient treatment or residential treatment, we really have to do a full assessment from the ASAM criteria, which looks at 6 dimensions. And those 6 dimensions are, taking a look at withdrawal and intoxication, looking at, psychiatric issues, medical issues, where are they on the trans-theoretical change and the risk of relapse and recovery environment. You look at all of these things to help determine, do they need to be in residential treatment or can they stay outpatient? And if they're outpatient, is it high intensity or is it just kind of standard intensity? And you only can do that if you use the standardized tools that have been developed to do that. And in California, the ASAM criteria is the mandated tool to be utilized in order to identify the level of care. So with Kayla, if we did all of that, she would look at a level 2 and a level 2 withdrawal management. And so withdrawal management is just another level that can be added on. So she would need to go to IOP and be monitored by medical for the possibility of withdrawal as she transitions to buprenorphine. So we can do this in 3 places. So we can do it in the office. This is what we would generally do. So we would have Kayla, most of the time, if Kayla came in and she was ready to get help and she had just used her drug, then what we would do is have her hang out at the office, and then we'd have somebody drive her to the hospital, and then she would go to OB triage until she started to withdraw, and then we would flip her. Some people would say, well, come in tomorrow after you've used and then we'll do it. But now that's one more use you're adding, one more chance to get HIV, one more accidental overdose risk, one more anything there. And so ethically speaking, I think it's difficult to justify saying, all right, go use as normal and I'll see you on Monday. It just doesn't make any sense. So what we want to do is identify for that person, what is the best thing that we can do. So if Kayla showed up and she's in a little bit of withdrawal, meaning a clinical opioid withdrawal scale of 8 or more, then we would induce her right there in the office. We'd give her the medication. We would do basic monitoring. We wouldn't need to monitor the baby or anything like that. We just make sure she's doing well, that her vital signs are stable. And after 30 minutes to an hour, she can go home. And then she can dose daily. It's really anticlimactic if they show up in a little bit of withdrawal. You don't want them to have a lot of withdrawal because that imparts its own risk more in the 1st and 3rd trimesters, but it's risky. And then hospital-based is where most of us who started seeing patients who were pregnant and inducing them, that's where we felt most comfortable because I could send them to OB triage if you have that, or I could just send them to the emergency department, call a buddy of mine and be like, hey, this is the pathway that we got to do. And basically you put them there, they hang out, hallway bed, give them a sandwich, let them watch TV, who cares? As long as they stay there until they start to withdraw. When they start to withdraw, we do an evaluation of their clinical opioid withdrawal scale. Once they get to about an 8, then we would give them 4 milligrams of buprenorphine and increase that as needed to where we get to a stabilizing dose of 12 to 16 milligrams, and then send them home and keep them on that initial dose until we reevaluate them and then make adjustments as needed past that. That's really the safest way that everybody does. But I'll tell you, after doing 50, 60 of these, almost all my inductions were at home now. Meaning, if you have a person who understands what you're saying, why you're saying it, can repeat it back to you, most people now have had an interaction with buprenorphine, whether they were in withdrawal and their dealer had it and they took it because they didn't want to be in withdrawal, whether they had been on it before, whether they had a spouse or a friend or a family member who's been on it. Most new initiates into treatment know about it, know when to take it, when not to take it. They recognize that it'll cause precipitated withdrawal if you take it with other opioids. So there's a lot less education needed than when we started doing this in the early 2000s, because the general population of patients and clientele understand what to think about. And that's a really important piece. So home induction is fine. If they have a safe location and we're going to do outpatient treatment, great. But the faster you can get them on medication, the better. So you got to make sure that if you're going to write a prescription and they're going to do a home induction, you call the pharmacy. You have a conversation with the pharmacy about, do they have the medication? Do they have the dose? Are they going to be able to pick it up? Make sure that they have that. Make sure that the insurance is going to cover it, that there's no prior authorization required. For Medi-Cal, there's no prior auth, but some of the commercials have it still. So just making sure that those issues have been evaluated appropriately. The right dose always comes up as a question. And I could spend an entire hour just talking about dosing strategies and what that means, but I'm going to break it down as this. So the Cochrane level database. So the Cochrane database is a database in medicine that we utilize once we have a large amount of information about something. They decide to do a Cochrane review, which means they bring together a group of experts. They review all of the literature out there, and then they come up with a determination of what that literature says, using statistics and math and expert opinion, all those things together. We accept it as kind of the standard when it comes out because it is done in a methodical, thoughtful way, and it has methodology associated with it. And it's not just a bunch of, egotistical doctors sitting around going, you know what I think? There's actually a methodology behind it, so that we can trust those outcomes. So the Cochrane level database says pretty specifically that anything below 8 probably is not effective for most patients. 16 is the only dose that's been shown to decrease the utilization of other illicit substances. Meaning, if what you're using as your outcome measure is a positive urine for heroin or oxycodone or other things, and they're on 8 milligrams, you shouldn't expect for that urine to have no other drugs in it if you're not giving them a therapeutic dose. A therapeutic dose for buprenorphine, especially out of the gates, is 16 milligrams. Over time, the Cochrane database, as well as a multitude of other studies outside of that, have shown that after 3 or so months, you can start to wean people down between 8 and 12, and it can be efficacious. And in some cases, patients can go down to 2 milligrams, 4 milligrams, and 6 milligrams. But to start at those low doses is not therapeutic. It's like if you have somebody with a blood sugar of 600 and you're like, well, I think we're going to start with 5 units of insulin. Let's start there. We'll see where we get. We'll see how we go. Well, after they get admitted to the ICU for DKA, we would think that that's probably was not a good idea. And it's the same with buprenorphine. If they need to be induced, we do it in a way and in a location that feels safe. We start with the appropriate dose of the medication. People will ask that, if I give 8 milligrams and they go into withdrawal, well, now what do I do? Well, you give another 8 because the treatment for buprenorphine-induced withdrawal from other opioids, or what we call precipitated withdrawal, is just more buprenorphine. So we overcomplicate this a lot. And again, I'm happy to answer questions about bup when we get to the end of this. But if they're on other opioids, we talked about how to make those things cross in the night, so to speak. And we don't want them to go into severe. And if they do go into severe, the biggest times of risk are going to be the first and third trimester. However, I think originally it was probably overstated. I've had people show up into my office in pretty severe withdrawal, and there have been studies that look at this and find that it's kind of a combination of withdrawal and bad luck. It's not just withdrawal that is the only risk factor. How do you make sure that you're seeing her right and giving her meds? Well, you start with the weekly prescriptions. The more frequently you can see somebody early, that's important. The other piece is making sure that you got her to the right level of care. So intensive outpatient is somewhere between 9 and 17 hours per week of dedicated therapeutic input. That's more than I saw you for 15 minutes 3 times this week. That doesn't mean you have to deliver it as a prescriber, but we need to identify an IOP program that can deliver that kind of care either telemetrically, which now we're rotating a lot of stuff with COVID out to telemedicine. Interestingly, the no-show rate for behavioral therapeutics has gone from 40 to 50% down to about 12 to 15% since we started doing behavioral health visits via telemedicine. So part of this, especially where you guys are, in a little more rural counties where there's an actual drive and gasoline required and, you know, motivation. And if kids are stuck at home, I mean, there's so many things that if somebody just has to pick up their telephone and go to a bathroom and close the door and have a conversation, they're much more likely to do that than have to figure out who's watching the kids. How do we get in the car? How do we get to go where we need to go? So making sure that we've set them up for that would be important. And frequent touch bases is important. We would do daily phone calls for our patients. It was just a medical assistant who would call and be like, hey, how are things going? Any issues? Just want to make sure we had any questions answered. That was great for communication, but it also decreased after hours panicky calls because we touch base with them on a regular basis early on. Urine or oral fluid tox screens, that's a vital sign early. It's helpful for you to understand where your dosing regimen is, or if you need to improve care in different ways, meaning do we need to identify a different location of care? Do we need to figure out how we get the addition of other testing and other things? Those are all things that can be done if you're following that vital sign of a toxicology study. Diversion control, this is an interesting one. So we found initially we would only see mom. We wouldn't see father of the baby or boyfriend, husband, whatever. And or whoever it was that was there, whoever their partner was. So when we were there, but then we noticed that people would run out early when we did pill counts. There would be short a few, and we'd ask them, and they'd be like, well, I gave my significant other some of these because they're also in withdrawal and they're having this. And then we identified that once we started treating their significant others, or basically the household in which they live, that we saw a significant decrease in diversion. And then the mother to be was actually more therapeutic on their dose because they weren't having to share it with a family of 4 who also had an opioid use disorder. And so family-based approaches to this, or household-based approaches to this, can be really, really helpful. The question always comes up with breastfeeding. The answer is yes, breastfeed. Breastfeeding is great. So we talked so the fundamental mishap in addiction is the dopamine levels in the brain. And if you have low dopamine, the only thing other than dopamine that can make you feel motivated is oxytocin. So breastfeeding releases oxytocin in the brain, and both for the baby and the mom. And that significantly stabilizes mood, as well as decreases the severity of any withdrawal symptoms that are going on. So just breastfeeding will decrease any feeling of withdrawal that mom has. And interestingly, if we have a baby who was born to a mother who's been on buprenorphine and she breastfeeds, then we decrease the neonatal abstinence syndrome or withdrawal from the kid, because they were getting a little bit of that tapered buprenorphine in the breast milk. And they only get about 1% of what they of what's taken. So they're getting a smaller amount. So it's like a natural weaning process with the addition of adding in the oxytocin over time and creating that mother-baby bond that's so important. This is agreed to by the ACOG, the American College of Obstetrics and Gynecology, the American Academy of Pediatrics, ASAM, American Academy of Addiction Psychiatry. Everybody who deals with this disease, either from the treatment of the mother or the treatment of the baby, agrees that breastfeeding in moms on MAT is appropriate and should be pushed. And there are some caveats to that, which if you need to, we can chat about a few of those. But ultimately, the advantages far outweigh any of the risks. If we look at methadone, so methadone, again, has been around for a while. We get stabilization of mom, both medical and social, improved maternal health, better participation. Now, all of these things also happen with buprenorphine, but they were originally kind of evaluated and discovered in methadone. And the reduced stress on the fetus is important because this also decreases the chances of OB flipping straight to a C-section based on what they see as a distressed neonate. So at the end, it's important, and it takes away the adulterants, meaning that if somebody's still injecting heroin, it's never just heroin in there. It's a whole bunch of stuff, and most of it is not good. And so it decreases the chances of infection and sepsis and fentanyl and just a bunch of other stuff, talcum powder and all this stuff that gets cut into these drugs, and definitely reduces complications. And again, the same things here. So reduced obstetric complications. So preterm labor was reduced by 30 to 40% as compared to those that were not treated. So that we rarely reduce things that much by a single intervention. So that becomes really important. And the other one is that it significantly decreases prostitution. So getting a mom on treatment and then maintaining that after delivery decreases the chances that we'll have a second pregnancy, a second unwanted pregnancy, if this was unwanted, but it decreases the chances of that. Now, if we go back to what we had looked at last time, we had looked at the brain, and these were the basic structures that we started with, right? We started with the prefrontal cortex, which is responsible for higher level problem solving, the corpus callosum, which is the right talking to the left side of the brain, the nucleus accumbens, which is part of the reward system, the hypothalamus, which is where our endocrine response to stress comes from, the ventral tegmental area, which is another part of the reward system, the hippocampus, which is where our memories are, periaqueductal gray, which is where our opioids and mood is regulated a little bit, in the amygdala, which is the emotional center of the brain. And then last lecture, we added the orbitofrontal cortex, which is where we assign value to things. And then the lateral habinula, which is the part of the brain that's responsible for default behavior under stress. And so I'm going to add one more. And this one is the locus ceruleus. And the locus ceruleus is the part of the brain that produces central adrenaline or central norepinephrine. So it is centrally responsible for not only some of the basic fight or flight, along with that lateral bed nuclei of the amygdala. Remember, we talked about fear and that piece. So when you add norepinephrine to that lateral bed nuclei of the amygdala, that rapidly induces a fear and a hyperacute arousal state. And so in that, we get hypertension, we get, your hair stands up on the back of your neck, you can get a little bit nauseous. So a lot of these things happen. You can get hypertension, GI distress. A lot of these things happen when we increase that norepinephrine in that part of the brain. So this is important because when somebody takes opioids for a long time, what that does is it inadvertently blocks the ability for the locus ceruleus to produce norepinephrine. So it blocks it, so the locus ceruleus is like, I need to make more norepinephrine, and I keep making more, and then it increases it to where finally it's shoving up against there so it can keep you awake and moving around. And if I remove that opioid, now I have an unimpeded overstimulation by this release of norepinephrine. And what that is withdrawal. So as we hold down that locus ceruleus norepinephrine, if somebody weans off of their opioids too rapidly, meaning let's say they used heroin 6 hours ago and it slowly comes off, and now all of a sudden we get this full release of that norepinephrine, then when we get that, that's opioid withdrawal. So most of the focus of what we're going to talk about for the remainder of this is on how do we evaluate and treat that withdrawal so that we can make sure that mom and baby stay together as a dyad when they're in the hospital. Because that release of norepinephrine is what we colloquially call, neonatal abstinence syndrome. And so as we look at this, you get, when you have that release of that norepinephrine or adrenaline, you get this hyperactivity, you get hypertonia where they're kind of, stuck together, like they're flexing everywhere. There's excessive suckling, high-pitched cries. If you've seen it, it's really distressing for everyone to see. And the initial treatment now, not used to. It used to be they would just like, here's some paregoric, which is just a combination of a bunch of opioids and things like that. And then it was methadone, it was morphine, and it's now buprenorphine a little bit. And but at the end, Yale has done a large amount of research on this, and what they found that makes the biggest difference is focusing on eating, sleeping, and consoling. Meaning, make sure that they're getting fed as often as they can, and make sure that they're sleeping and that they're consoling. And the way that you do this is that you swaddle, You have mom room in with the baby so that every time they get a little irritable, mom can hold the baby, they can breastfeed, you get oxytocin, you get a decrease of that norepinephrine production naturally. It's pushed down by the periaqueductal gray, pushing down with these opioids that are produced, your own endorphins. So all of those things improve. And the interesting piece was, a few years ago, they did this nationwide Vaughan study where they were trying to push out improvement of treatment of neonatal abstinence syndrome in the ICUs around the country. And the average length of stay was like 21 days for a neonatal abstinence syndrome kid at that point. And they improved it from 21 days to 17 days. So a pretty significant improvement. The Eat, Sleep, Console, which almost never uses medication, decreased it down to 7. So just doing the things that we know is right, keeping the mother-baby dyad together, allowing for breastfeeding, making sure that they're getting good sleep, and that good sleep has to go with making sure they're being rocked by someone consistently. Things we would do for our own frustrated, angry child in the middle of the night when they were babies. We just want to do those in the NICU, because what we were doing is assessing this withdrawal with basically a naked baby laying under a warmer and wondering why they were crying so loud. And if you just swaddle them and give them to mom, the score that we use, called the Finnegan score, which we're slowly moving away from even scoring that and just focusing on, are they eating okay? Are they sleeping okay? And are we able to console them? And if you're able to do those using these basic techniques, skin to skin, certain holds, having mom there and breastfeeding, if we're able to do that, we don't need medication. And in fact, now the vast majority of the time in the hospitals that have adopted this, and we try to do a statewide push for this along with MCQCC and CPQCC at Stanford, which is still ongoing. We're trying to roll it out where people are more aligned with the Eat, Sleep, and Console pathway. And then we have less need for things like morphine, methadone, buprenorphine, clonidine, phenobarbital, all of this other stuff. And most of these kids never even need to go to the NICU. Most of these kids just, go to the regular nursery, and a lot of them go home with mom with close follow-up now. So we're getting to the point of, like we normally do, we see something, it freaks us out, we over-treat it, and then as we get comfortable with it, we're like, oh, we probably don't need that. Oh, we don't need that. Oh, if mommy hugs them, that's good. Crazy. So if we start to look at these pieces, we just have to understand that the basics still work here. And the focus of all the stuff that we're really trying to treat is this unabated release of adrenaline through the locus coeruleus in the brain, causing all of these things to happen. And recognizing, like I said earlier in the talk, that things like an SSRI and nicotine and marijuana and benzos can worsen withdrawal, especially if not recognized early. And then we'll find kids in the NICU for, a month, and we think we're treating opioid withdrawal, but what we're really treating is benzodiazepine withdrawal. And generally speaking, if mom's being treated appropriately for that, then breastfeeding whichever medication, whether it's gabapentinoids or if it's continued benzos, will decrease that. Now, we know that there's a risk of mom being on benzos during pregnancy. So you can't just stop those, because there's a significant risk of prolonged withdrawal syndrome and seizure disorder. So you go to longer acting, you decrease the totality of it. And I'll just say that the review of that literature is scant at best for overt risk. We know that it's higher risk, and so we don't say that it's good to do it. But when you're looking at a thing of risk benefit, it's better to slowly wean mom off of benzos during pregnancy and get to the lowest dose that does the job at the end, or off if you can. Generally, it takes 9 to 10 months to wean somebody off of benzos. So most of the time you can't get it done by then, but you're still doing a good thing if you continue to wean through pregnancy. But recognize that's going to worsen your neonatal abstinence syndrome. So what does this mean for Kayla? We talked about her. So Kayla, she would probably do really well on buprenorphine. And in the case when we treated her, she did. We started her at 16 milligrams, and after a month, we had her on 12, and she stayed on 12 milligrams throughout pregnancy. We did not do an inpatient induction for her because she was somebody we had seen far into our experience on this. And so we did a home-based induction with a telephone call and a follow-up. She got a tox screen every time. We had 2 where she still had used some heroin, but we had a good conversation about that, and we were able to have her work through that by adding on those coping strategies and giving her a peer to talk to when she started to feel uneasy or worried about things, and then working on that behavior change so that she found value in staying in recovery, and her default reaction was to call her peer or to do a mindfulness exercise rather than default to the use. And buprenorphine is absolutely better for neonatal abstinence syndrome, especially if you're adding in breastfeeding and the eat, sleep, and console. And then post-operative pain treatment for mom can be scary, but it's pretty straightforward now. You just maintain them on the buprenorphine and treat their pain as they need it. It's not like we didn't have to go through all these imaginations that we talked about in the early 2000s. We're like, we got to stop it or put them on methadone or switch this over or change this, make the earth turn its other axis. We didn't have to do that. You just maintain them on their buprenorphine, and most of them you can just increase the buprenorphine while they're hospitalized, and that treats the pain. Or you do short-term PCA for a C-section, fentanyl for like a day, and then you use ketorolac, acetaminophen, and then increase their bup. So there are a bunch of different ways you can do it, and but it's usually the easiest way that does it best. Just to quickly walk through some of the basic outcomes that we looked at for methadone. This is the mother study plus some added numbers that came in. So when we look at the end, these are the numbers of studies that were combined together to create these numbers. And so when we looked at this, we found days in treatment for methadone was about 99 for mom. So these are maternal outcomes. And then a statistically significant difference of 115, which doesn't seem like much, but it's an extra couple of weeks that was mean in treatment. Now, they didn't do follow-up for who bounced back into treatment. This was just they missed their treatment appointment 2 times in a row. And then preterm birth was, percent, 0% with preterm and about 10%, which goes with most of the methadone literature. And then positive tox on delivery was 0 and 9.1 for that. And then the birth outcomes, as we look through here, percent needed treatment for neonatal abstinence syndrome for buprenorphine was 20% and 45% for methadone. So from this standpoint, buprenorphine seems to be superior. And the amount of morphine needed was a lot less. And then the birth weight was higher, and length of stay by the baby was a lot less as well. And percent in the NICU treatment was statistically significant less as well. So it is probably now, if all things being equal, probably the gold standard would be to initiate buprenorphine if at all possible. But obviously any treatment at the very beginning, stabilizing mom is great. And this just kind of goes over NAS time course. These are the Finnegan scores, like the peak of scores. You can just basically see that methadone was always higher than buprenorphine as it went, and it became a little more unpredictable long-term as it went. But again, we're doing away with these scores, but the data is pretty clear that if you have to pick one, buprenorphine seems to be the superior medicine for NAS. For this last couple of minutes, I want to talk about the website that we built with Stanford. So this is nastoolkit.org. I'm going to actually open it up and see if we can go to it. I'm probably going to have to stop sharing and then pop onto my other screen so we can see it. Let me just do that. And then I'll reshare for everybody so that we can see the toolkit. There we go. And so if you see here, you come to this website, the nastoolkit.org, and you can either just start from the beginning, or you can read about Kayla, you can read about baby M. You can decide on where you work. So if you work in the outpatient space and you want the best practices for that, or labor and delivery, or the NICU and nursery, you can search a topic. You can filter it based on what you want to learn about: screening and assessment, treatment, transitions of care, education, and wherever you decide to go, it'll take you. Let's say you work in labor and delivery. It'll take you here, and it'll talk about, here are the best practices for screening and assessment level care determination. Here are the best practices for treatment. Here are the best practices for transitions of care. And here's the education that you should be providing in there. If we go back to audiences and we want to look at it a different way, and you just want to look at screening, then we can go into, here are all of the screening pathways for outpatient, and it's still broken into labor and delivery and NICU. So you can still look at the ones where it is, but you can see the other ones as well. And then if you go into the best practice, this will tell you that this is for outpatient and about screening and assessment. And we're loading a bunch of videos on here right now for these so that we can have you can just watch these or listen to them rather than having to read it. And then it goes through these overviews and down these pathways as for the checklist and what a deep dive is and that. So feel free to go deep into these and look around. These are important, and but it's all right here. And these were done from national leaders in this field. It wasn't just a couple of people. There were about 60 authors for this website, and we maintain this being updated on a regular basis. So with that, I'm going to come back to my main screen. And we'll finish us out here. So in conclusion, you got to treat mom. If you don't treat mom, baby's not going to do good, man. You got to maintain the dyad. That's the whole point. And the neurobiology, again, matters. Eat, sleep, and console. It works better than the drugs. You got to just focus on those pieces. Mortality for mom is highest after delivery. Remember, we're not done if we're high-fiving delivering a happy baby, that's great, but you better be high-fiving a year later while she's still in care. And this is how we stop the cycle. This is the best group of people to treat. It's so much fun. And if we had to identify what is the one place the two places we should be treating patients, I would say it's in justice-involved individuals and pregnant moms to be. Those would be the two people I would choose if I had to pick winners on that. And that's what I would suggest for sure. References here, I mean, you'll have access to these, and then there's some questions you guys will be getting. It's no fair if you actually really saw that because the answer was on it, but that's okay. All right, let's go to any questions. I know I'm hit right at time, but there's a lot of stuff to talk about. So let's see, QA. The URL is NAS Toolkit. Yep, that's it, nastoolkit.org. Great. Any other questions? Nothing. We're all experts in neonatal abstinence syndrome, prenatal screening, assessment, level of care determination, buprenorphine dosing, pharmacology, and neuroscience. Yes, I have succeeded.
Yes, you imparted your wisdom. Now we're experts. Thank you, Corey. Hi, everybody. I'm Shelley Rogers from Granite Wellness Centers. I guess there might be another question coming in. Let's see. No question, just incredible info. Yeah, agreed. We are so honored and grateful to have you, Corey, here sharing your expertise with us in all the sessions. Have been amazing so far, and we're looking forward to the next one. All this critical information that supports all of us in this field, working with young adults, youth, and families. So Granite Wellness Centers was able to bring this to you all through funding from the California Department of Healthcare Services, a grant with the youth opioid response. And I just wanted to say real quickly, we've had questions about continuing education credits. Just a reminder that you're all going to receive links to the evaluations after each session, and that once we're done with the last session, you'll receive, we'll begin to process your certificates. So one CE for each session, and the CEs that we're able to provide are CMEs, thanks to the Cooperative of American Physicians and Placer Nevada Medical Society, and also BRNs, thanks to Nevada County Public Health, and CCAP, continuing education credits for counselors, thanks to Granite Wellness Centers. So we were not able to secure the BBBS at this time. Many questions have been asked about that. So that's all I have, and it looks like maybe there's more questions. I don't know.
Yeah, I typewritten an answer to one of them, but I think it bears chatting about. So WIC, we try to get involved early, and I think they were involved in an informational standpoint, but we really need to disseminate a lot of this information at depth to those that work with WIC and around there. And that has not been done to the level that I would like it to be done. And I've talked to DHCS about that, but we were planning on having a combined conference so we could really dig into it. But, you know, COVID occurred. And so some of these things are becoming more logistically troublesome.
Yeah. We would like to share the toolkit on our websites as well. So
Yeah, feel free. It's open source. It's paid for by DHCS, the SOR funding that came down, state opioid response stuff. So, yeah. And we'll continue to update it. We have a 5-year plan to update it, make sure that we're going to be adding videos. We're going to be adding some chats with the authors, things like that.
great. And then I did see someone ask about the recordings. The recordings will be, the links to all the recorded sessions will be sent to everyone. Thanks for your patience as we kind of navigate all of that and getting them all uploaded on the YouTube platform and then the website in order to send the link. So that they will be made available. William Davis asked hasn't received the surveys, so we will make a note of that, and you should have. So we have you and your registration information, so we'll reach out to you after this session.
Yeah, and another website, if you're interested in some more on the work that's been done, is the addictionfreeca.org. I think I had mentioned that one before. So it's just addictionfreeca.org. It's all one word. And that is a consolidated picture of all the work that's been happening across the state of California. But it also, you can hover over your county. So you could hover over Placer in Nevada County and identify all of the grant work that's been done in there and what's been captured through that informational session and those that were a part of it, so that maybe you can even identify partners that you can work with on some of these things. And that website is continually being updated with new information. It's connected to national databases and things. And we're about to actually overlay COVID data as well, so that we can overlay with overdose data with COVID information, so that we can start to identify how COVID is impacting overdose on county-based overdose data. So, so hopefully we should have that up in the next, it's just a matter of connecting databases at this point, and we're in the process of doing that. The feds have made that difficult at this point, since they've changed the trajectory of information from the CDC database to having to go through the executive branch first. So that's a little frustrating, but we're going to work around that.
That's great, Corey. And you said that's going to be available on the addictionfreecalifornia.org site?
It's just addictionfreeca.org.
Addictionfreeca. Okay.
Yeah. Mm-hmm.
Excellent. Let's see, any other questions? I think that might be it.
All right, great.
Thank you so much, Corey.
No problem. It's great to see you guys. Everybody, enjoy the rest of your day. Be safe.
You too.